How's it going, Z-Pack? It's your boy Z-Dog MD. Check it out. I'm live and direct from my backyard, my rental backyard. It's the same difference, really, because I'm staking a claim. I've urinated in the corner. I've marked my scent and my territory because that's what we do. I'm outraged. I don't know if you guys are outraged, but Tom sent me a Business Wire release, which is effectively a press release from August 2nd, which I believe is that today? I don't even know. I've lost track on my radical sabbatical. But it's from Press Ganey, the company that brought us patient satisfaction scores and Press Ganey scores. And it's a for profit company that purports to measure patient experience for the benefit of improving quality and outcomes, the intersection of safety, quality, patient experience. But now they've added another piece called provider experience. And listen to this. Press Ganey introduces first quality indicator to measure assaults on nursing personnel with unit level data and comparisons. What? Let's read that again. Press Ganey introduces first quality indicator to measure assaults on nursing personnel with unit level data and comparisons. Okay, I don't know if the irony of this is lost on you, because it certainly isn't lost on me. The idea that since Press Ganey's come around and hospitals have kind of been beholden a bit to a lot of quality measures that maybe don't necessarily measure quality, but do measure things like, how quickly you got your sandwich, that sort of thing. Now, there are other measures of patient experience that are very important and probably do correlate with actual outcomes. And there was a recent New York Times article talking about some of the facilities with higher patient experience scores actually had better outcomes for mortality. And again, there's data showing things both ways in the patient experience literature. So the irony being that since hospitals have been so focused on the patient experience, it seems increasingly like they're unfocused or willfully ignoring the caregiver experience, and that includes frontline nurses. So and I've heard this time and time again from feedback that I've been getting through Facebook messaging from people, healthcare workers on the front line, saying, my hospital would rather ignore uh, violence against us as providers than talk about it because it will hurt their patient satisfaction scores. It will also give the perception, if they add a lot of security, that this is a military unit on lockdown instead of a welcoming, opening, dare I say, hotel-like experience for people who are hospitalized. So in many ways, many people on the front lines feel that the Press Ganyification, if you will, of how hospitals are reimbursed, paid, judged, etc., has contributed to the epidemic of unreported hashtag silent no more violence against frontline healthcare workers. It has contributed to the opioid epidemic. Give patients what they want so that they get that fantastic hotel-like experience with their Dilaudid and their turkey sandwich, and everybody's happy in terms of revenue generation, survey results, satisfaction scores. Doctors feel hamstrung by this. They have to do the thing that's right for the survey. They're playing to the test, but not necessarily doing the right thing for the patient. And many refuse to play that game and they suffer, right? So I thought it was with not just a little bit of irony that Press Ganey is now introducing a quality indicator that is revolving around the caregiver experience, specifically assaults. So let's go through their press release. And I don't want to share it because I don't want to help them further sort of commercialize what they're trying to do here, because part of my intuition is this is a bit of a PR plug. Part of me thinks maybe they're actually trying to do the right thing because they realize that the fourth piece of this, the caregiver satisfaction piece, actually contributes to better patient care, better outcomes. When caregivers are happier and feeling supported and safe, patients are supported and safe, and actually the whole enterprise is more profitable. So maybe they've finally connected with that. Maybe they always knew it, but they're just now catching up with the logistics of it. Or maybe it's all PR. So you guys can tell me, because y'all, and I see Deb Bennett already says absolutely just PR. So true, I can't stand Press Ganey, says Peggy Laird. Nope, says Janie Garner. So it's clear that frontline practicing professionals effing hate Press Ganey. There are very few who are like, yay! In fact, one of the funniest stories I heard was I was supposed to speak at a particular hospital. And the hospital canceled me because I was, quote, too expensive, or some other explanation they had. And they replaced me with one of the leadership of Press Ganey. So this Press Ganey person came in and spoke to the hospital staff about how important it is to have a great patient experience. And you can believe me that I got a lot of private messages from the hospital staff who were like, are you freaking kidding me? They baited us in with ZDogg and then they gave us Press Ganey. It's kind of like, how tone deaf can you be for frontline healthcare providers? I'm not saying I'm this wonderful thing. I'm just saying Press Ganey sucks. So anyways, you can tell where my elephant bias is, and I'm going to put it on the table. I'm biased against companies that are making a profit by optimizing Health 2.0 to the expense of the caregiver-provider sort of component. Now, if it's true that they're pivoting a bit, that's great, and I'll commend them for that, and I want to support them. But if they're not, and it's PR, let's see what their PR is. Press Ganey is not our friend, Gail Cardoza. That's right. We have a bit of Stockholm syndrome sometimes with these guys. It's kind of like we love our captor. Boston, Press Ganey today announced the industry's first nursing-sensitive quality indicator for assaults on nursing personnel with unit-level data and comparatives. Wow, even that language just makes me slightly ill. But the indicator, part of Press Ganey's National Database of Nursing Quality Indicators, or NDNQI, like we don't have enough fucking acronyms in our lives, guys. Like they're going to give us NDNQI now? Wow. With a little registered trademark. Look, can you see it? There's a little registered. You can't. The little circle R. Solution. Sorry, I forgot to add the solution because Hitler had a solution too. Okay, now I'm just getting silly. Was developed to help hospitals better understand and assess workplace safety and rates of violence against nurses at a time when these are reported to be at epidemic levels. You think, Professor? Epidemic levels? Why? Why? Let's dig into why that is. Partially, it's the patient satisfaction industrial complex that has driven a customer is always right attitude, which is not productive in healthcare and allows abuse. The patient experience is crucial. It is important. It has been under recognized and underappreciated and also under optimized by far. Anyone who's been a patient knows that, right? Especially medical people who are patients. But is this the answer? So let's keep reading. Development of the measure supports the company's focus on nursing excellence and follows its recent proprietary analyses that found significant relationships between nurse perceptions of workplace safety and patient experience and clinical outcomes. Slow clap, Press Ganey. You had to study something to prove that what was already printed in the New England Journal of that when nurses are happy and feel supported and feel safe, patients and outcomes improve. Could you go ahead and tell this to all the administrators and hospitals whose butts you kiss, trying to get them to use your product, and the administrators who feel hamstrung by the scores that you use to measure those quality things? If we could actually have some connection between the quality czars, the Health 2.0 arbiters of numbers, and the actual frontline healthcare providers, and actually put our money where our mouth is about this stuff, then we could actually build Health 3.0 together. So again, I want to modify what I'm saying to say I'm not against measuring quality. It's doing it correctly. So if this is true and they actually, they found this, right? Let me read this again. Its recent proprietary analysis that found significant relationships between nurse perception of workplace safety and patient experience and clinical outcomes. This is from the Journal of the Obvious. I'm glad they measured it. It's so proprietary what they measured that any freaking nurse on the front line could have told you, hey, we're happy, we feel supported by administration, we feel safe on the job. Guess what? Our outcomes are great. Our patients are happy. Everybody's doing well. Duh. You don't need a proprietary analysis to tell you that. So to provide patient-centered care and be both engaged and resilient in their roles as caregivers, nurses must feel safe in their practice environment, said Christy Dempsey, Chief Nursing Officer, Press Ganey. Okay, Christy, I'll buy that. This indicator can help organizations prioritize workplace safety and delivers insights needed to nurture a culture of nursing excellence. So Press Ganey is kind of saying, and we can provide you the measurement tools that are scientifically validated to show you that your nurses feel safe. So again, thank you, Press Ganey, for all the wonderful work you've done to make medicine a better place. The scientific measurement and data collection process of NDNQI solution better equips organizations to take steps to prevent workplace violence and improve nurse and patient outcomes. Okay, now if this is true, right, I can't imagine how much the administrations have to pay for this stuff. That could be spent actually improving nurse staffing ratios or training people in de-escalation techniques or improving security at the hospital, right? Powerful unit-level data and reporting enable targeted action planning and intervention for specific units. The new indicator's innovative insights raise the bar on the standard of nursing excellence by acknowledging and supporting the safety of nurses and the importance of their work environment in the delivery of safe, high-quality care. The indicator can also be used to help organizations meet the EP18EO requirement for Magnet Recognition Program registered trademark. So once again, we are teaching to the test. So here's a new product we've developed that gives lip service to to nurse safety and assault by measuring it so that you can meet the click box to become a Magnet organization. Is it a start? Maybe. Is it a further perversion of the precepts of Health 2.0, which is the measurement industrial complex for healthcare, right? The dehumanization, the commodification, the assembly outlineification of healthcare. Is it necessary for Health 3.0? It might be. Is it sufficient? Hell no. Should we just sit back and accept when the czars give us this stuff? No. We should talk shit about it. We should argue about it. But we should also say, hey, if it's going to work, if it's going to help keep nurses safe on the front lines, if it's going to actually at least measure the problem so that then we can act on it or tell our legislators or our administrators, here's the problem, here are the numbers, right? You can't sweep it under the rug. And guess what, though? Guess what's going to happen? Hospital administrators are going to realize really quickly how to game these numbers because you're going to hide the data. How are you measuring it, right? If you can sweep an act of violence or assault or threat or a verbal threat or an emotional threat under the rug, aren't you going to do that because it's going to improve your score? So to me, could this even make the problem worse? We don't know. That's the law of unintended consequences with the measurement industrial complex that's Health 2.0. Let's keep reading here. Oh, there's nothing else to read because that was basically that was the press release. You see now why I'm not going to share the link to that because I'm not going to perpetuate this shit. So here, let me get to your comments because I think I want to talk about this from your angle and not just hear me keep blethering on. Let me pull up your stuff. I kind of like this iPad as the recording device and iPhone as the comment device. So here we go. Misty Shine. We participate in the NDNQI with 90% participation within our facility. The problem? No one looks at the results or analysis of those results. This data never makes its way to the C-suite, and the staff look at these bar graphs with blank looks. Yeah, lots of good, not. So that's interesting. So maybe the data gathering is a useful thing, but if it's not acted on, if it doesn't actually have actionable results, if you're showing all this nurse assault, nurse violent, if we are continually silent rather than silent no more, does it actually do any good? Robin Craig, please discuss magnet status hospitals in a future post. Yes, I want to get some experts in magnet to come and talk about it. I was supposed to speak at the magnet conference, ANCC, in, where was it? Houston this year. And they canceled me. No explanation given, so you can actually reach out to them if you have a question about why I was canceled, but they canceled me, so I'm not going to be doing that. So I have no idea why. They were very nice people that I worked with there, but apparently they changed their whole emphasis. So I have a little bit of weirdness in my heart for Magnet because I was supposed to speak there the year before, but I got canceled by a hurricane, which was kind of a bummer. So something in me and Magnet just don't really connect. Magnet certification causing great nurses to leave the field. ADN, BSN, who cares? Not the patient. Edna Mole. So again, more Magnet love. What the hell? I'm from the dark side administration, and this reeks of BS on a hot, humid day. Mary Weheimer, or Wiemeyer. Thank you, Mary. Thank you for recognizing BS when you see it. Our best administrators try to work within the bounds of Health 2.0 to optimize it so that we can actually take care of patients. And our worst administrators they give up. They feel like there's nothing we can do, and we just are slave to this stuff. So I like Mary's attitude. Shirley Black, we need to individually report incidents to a national data collection so hospitals cannot bury these incidents. Maybe that's the result. Maybe we should create it's not very scientifically valid, that's a thing, like some kind of poll within ZDogg Industries where you can report the stuff to us through a form on our website. That might be interesting. Then we can present that data to the authorities. So that's a thought. Janie Garner, that's one of my favorite topics. So Janie, you can weigh in. Janie is the bomb, has her own social media empire, and I'm sure she comments on this on the regular. Lori Wenzel, magnet status doesn't mean much to me. Presence St. Joe's was awarded magnet, and that made no sense. Remember, ED nurse boot camp and the RN strike vote. No one is sure who the magnet team spoke with. So there you go. Isn't evidence-based practice the more educated the nurse, the better the patient outcomes? Heather Walker. Well, you would think, right? But also the more supported the nurse, the safer the nurse feels. You know, I've worked in environments where everybody supports each other and they practice at the top of their game, and it's team-based in service of each other and the patient, and that's called Health 3.0. We tried that very strongly at Turntable. We weren't perfect, but we were pretty close, and I think we had some pretty good outcomes and pretty good patient, actually I know we had pretty good patient satisfaction. We did something called Net Promoter. It's a simple question. How likely are you to recommend your team in this clinic to your family, friends, and loved ones? And we were 90% positive, which is unheard of in the healthcare space over the course of, a year and a half when we measured it. Ola from Texas, Holly Modal. Ola to you. Christy Columbus likes the visual angle, the cedar shingles and the woods. It's super cute. I really love Portola Valley where we're staying. We're going back to Vegas we're going back to Fresno, Clovis, where my parents are on Saturday. We're going to do a couple shows from there and then back to Vegas and back to the studio with Tom and Logan. So stay tuned for that. Carrie Hinchliff, complaints about food, not having the dessert, etc., aren't damaging to hospitals directly here in the UK. So this is astounding, but complaints regarding actual care are. For example, if someone complained that a frail patient is not being assisted to be fed, and they should be, that would actually, what is it? That said, there's no unofficial frowning regarding any complaints. So in other words, Carrie's pointing out that in the UK, the measurements are supposed to focus on actual care, which if that's true, that's fantastic. I recently ran a mini study in my CCU using Maslow's burnout inventory, says Steph Gayhart. Guess what the results show? Taking it bigger and then talking it, wait, what is this? Taking it bigger and then taking it to the higher ups. Oh, I see. Guess what the results showed? Probably a lot of burnout. So now she's making it bigger and taking it to the higher ups. So again, there's this grassroots data collection, right? Small data where we're trying to show what's going on in our own backyard, right? I work in a unit with children, says Jennifer Petty. We have more assaults against employees than any other unit in the hospital. We do not give any chemical restraints, but just physical holds and seclusions. So Jennifer, with kids, it's tough, right? Because the behavioral issues are somewhat different than adults. And how do we make nurses safe and supported? And how do you de-escalate a child? And how do you manage, somebody with a behavioral overlay, medical condition like autism, etc.? It gets very complicated, but we have to talk about it. Let's see. Based on actual care, says Misty Blue. What a novel idea. Heaven forbid. And how do you measure that? How do you measure quality in actual care? What are the quality measures? So often, my friend at the University of British Columbia, professor of pharmacology up there, has often pointed out that we measure surrogate measures. And those surrogate measures like hypertension, glucose, hemoglobin A1C, they don't really correlate to actual outcomes in the real world that matter, or the statistics are, if they do, it's so subtle that you'd have to treat, a ton of people to show any benefit of aggressively lowering a hemoglobin A1C with medications. So what is quality? Does it have to take the patient goals, hopes, dreams, fears into account? Does it have to take provider experience into account? Does it have to take bigger picture measurements like quality of life, like how do you measure that, right? So if we can get those measurements, and so far the measurement industrial complex, the Press Ganeys of the world haven't figured that out, right? So they're starting at the simplest stuff, which may not correlate to it may not actually be causative of real outcomes. Lindsay Johnson, you nailed this on the head. We're missing the human context in our data. It's all for show and the business and money. There you go. That's where we are in Health 2.0. Now 3.0 transcends and includes 2.0, so it has to include some degree of understanding measurements and data and patient satisfaction and those kind of things, but it takes the stuff that actually works, quality measures that maybe measure quality, and it incorporates the patient voice, the physician, the nurse voice, the administrators, everybody in a team taking care of the patients with outcomes that matter, not just for the patient, but for society at large. So you have to look at systems thinking, but also drill down to that unique patient who's sitting in front of you. And it's very difficult to do, but it can be done. And we've seen glimpses of it and bright spots of it emerging. That's how new sort of concepts emerge in the world in general. You'll see a couple of bright spots pop out, and they seem very revolutionary, and then things start to rapidly catch up and emerge. And as we start entering the age of exponential technology, technology will be a driver. Right now it's a hindrance of a lot of the humanity of healthcare, but as things start to emerge, novel technologies will arise that will actually drive better care and more humanization and uniqueness of care, personalized medicine, precision medicine, etc., with the analog heart that is the human relationship that nurses in particular are very good at, and doctors can be very good at if they're freed and actually paid based on real outcomes, which right now doesn't happen. Let's take some more here. Pain as a measuring tool needs to go away. I'm an ER nurse now, and for 13 years, guess what? With an acute injury, we may never be able to make your pain go away. We may save your limb or life, Rebecca Hendricks. So this is one of the big controversies now in this opioid epidemic and crisis is, have we been over treating to the numbers around pain and now creating a culture where we accept zero pain? And pain and human suffering, the Buddhists have been saying this for millennia. Suffering is a part of this world. It's what we do. It's how we frame it and how we perceive it that turns pain into suffering. Suffering is different from the experience of pain. You can have pain without suffering, and it's how we frame it mentally. And right now we're framing it as, no, any pain is suffering. Therefore, you will suffer if you have pain. Therefore, we will overtreat it with narcotics, and then you will see the real definition of suffering, which is dependency, addiction, patients with real pain being stigmatized for using narcotics, the whole nine yards, right? Julia Maddox agrees, yes, overtreating pain. Coming from a surgical ortho floor, they expect a pain scale of 0 at all times on a surgical ortho floor. Anyone who's done ortho, and I've done quite a bit of it because of, because as a hospitalist, we consult on the ortho service all the time. You come out of a knee, you are going to get out of bed that day doing PT, and it is going to hurt incredibly. But that's the kind of pain that you reframe. Instead of suffering, you go, this is what's going to help me rehab my knee and improve motion and improve function quicker, right? And that's how you have to frame it instead of narcotizing the hell out of it. And then you end up with ileus and constipation and dependency and all the other things that go with opioid overuse, including the mental fogginess that can slow recovery. The H in hospital doesn't stand for Hilton, says Nova Woods. Now, speaking of H and Hilton, patient satisfaction, getting paid. I'm going to get Tom and Logan paid a little bit by doing a Facebook ad break. I met with Facebook this morning with their ad break team and other people on their team to talk about a bunch of stuff that I can't talk about under non-disclosure agreement, but understand this, Facebook is trying really, really hard to engage with creators like myself to allow this platform of Facebook Live to become bigger, to really be a better experience for the end user, you, and allow us to be financially sustainable doing what we do. So check this out. Me and a handful of other creators get to do this thing called ad breaks, where Facebook targets a special ad to you, and for 15 seconds you watch it. Some people won't get an ad because Facebook only has a certain pool of ads to deliver, and some people will. And then when you come back, we'll talk about it, and it makes me a little bit of money that helps to fund our expenses like our cable internet costs and things like that. Logan's diaper money. Here we go. Tom's vape costs. Thanks for sitting through that. Let me know what you saw. Pat Hughes makes a great comment. Hospital refuses to give IV Tylenol because it's too expensive. Would rather up the narcotics. Narcotics are cheap. There you go. Short-sighted policies, which are exactly what happens when we're cost and profit driven instead of outcomes driven. If we were actually paid for real outcomes, everything would change. It's just hard to do. Guys, it has been moderately to severely real today. I hope you enjoyed this episode. Do me a favor, hit share. Tell your friends about this. If you want to donate, support the show on Patreon, you can. It's just patreon.com/ZDoggMD. But I'm more concerned with you guys sharing these and spreading the word and us growing the tribe, because a big tribe means we can actually accomplish things in the Health 3.0 movement, in the Silent No More movement. We can inspire others to make change and to start groups, as has been happening. And we need your help to do this. We need you to spread the word. I know there's a lot of fear out there. I hear this in the comments. People are afraid they're going to lose their job if they speak out on social media. So by all means, be careful, but also understand that there's power in numbers. And at some point, they're going to realize we aren't a commodity. We are a precious resource that should be protected and encouraged. And people like Press Ganey may even eventually get on that bandwagon. All right, guys, I love you. We out.